Ready. All right. Hello, everyone. We'll be getting started. Hello. My name is Jacob Baticki, and I'm the Director of Translational Research, Policy, and Education at the University of Miami Public Health Policy Lab. The UM Public Health Policy Lab and the AHF Global Public Health Institute are honored to welcome you to our Emerging Challenges in Global Public Health webinar series in this hybrid event, a forum dedicated to knowledge exchange, rigorous discussion, and actionable solutions to the most pressing issues facing global public health today. Today's conversation, Navigating a Fragmented World, a conversation on the future of public health, comes at a critical moment as declining global health aid, persistent gaps in the global health architecture, and growing nationalist pressures reshape our landscape. We gather to explore both the challenges before us and the pathways forward. It is with deep gratitude that I welcome our distinguished speakers, Dr. José Szapocznik, Chair Emeritus of the Department of Public Health Sciences at the University of Miami Miller School of Medicine and founding Honorary Director of the UM Public Health Policy Lab. Dr. Szapocznik's enduring contributions to public health scholarship have shaped our field and continue to inspire our work today. Also, Dr. Jorge Saavedra, Executive Director of the AHF Global Public Health Institute. Dr. Saavedra earned his MD from the National Autonomous University of Mexico and holds both an MPH and MSc from the Harvard T.H. Chan School of Public Health. His leadership spans regional and global health governance with particular expertise in navigating the evolving landscape in international health cooperation. And Dr. Ana Palacio, our moderator and director of the UM Policy Lab. Dr. Palacio is a professor of clinical medicine, a clinician investigator, and an epidemiologist in the Department of Public Health Sciences at the University of Miami Miller School of Medicine and the Miami Veterans Affairs healthcare system. Her research focuses on social and environmental determinants of health, health disparities, chronic disease management, and health policy. I would also like to welcome Dr. Catherine McAllister, Interim Chair of the Department of Public Health Sciences and Professor of Health Services Research and Policy at the University of Miami Miller School of Medicine. As an accomplished health economist and principal investigator on multiple NIH grants, Dr. McAllister has secured over $10 million in NIH funding. She plays key leadership roles in national initiatives such as HEAL, JCoin, and Cherish, and the HEAL Data to Action Modeling and Economic Resource Center. Dr. McAllister, welcome.
Thank you so much. What a lovely introduction. It's really a pleasure to welcome you here today. I have a few opening remarks, and I'm just going to refer to my notes so I can be efficient, but it's really a pleasure to be here. Public health has always, being such a huge field, it's always been a bit fragmented, but it feels more fragmented than ever today. In moments like this, I find comfort and inspiration in looking back at people who actually managed to create meaningful, lasting change. Dr. Szapocznik's career is a masterclass in how to do that. His stats are impressive: over $125 million in NIH funding, more than 300 publications, and he's consistently ranked among the top funded investigators globally. But what really matters is what he did with all of that funding. Every major initiative Dr. Szapocznik led was designed to bridge the gap between research and real-world impact. He didn't just want to publish papers. He wanted to change how we deliver care. The Center for Family Studies that Jose founded became a powerhouse for developing interventions that practitioners worldwide actually use: brief strategic family therapy, multidimensional family therapy, and Familias Unidas, all very well-known family-based interventions that are not just evidence-based interventions sitting in academic journals. They are actually tools that change lives. Dr. Szapocznik has been the PI of the Florida node of the National Drug Abuse Treatment Clinical Trials Network, CTN as we call it affectionately, since 2000. And this is now funded through 2032. Seems like a weird, to be able to say that. It's not so far in the future, but very well-funded and long-standing initiative, representing over 3 decades of sustained investigation on interventions that actually reach people, translating evidence into the community and into effective treatment. He also expanded this work throughout the Americas and globally. When he chaired our Department of Public Health Sciences, starting in 2008, he established the 5 divisions that define us today. He also supported the launch of our MD-MPH program, 2 MS programs, and 2 PhD programs. He also built infrastructure that was genuinely innovative. The Miami WHO Collaborating Center and the Miami CTSI. And the Miami CTSI is different from other CTSIs as Jose designed it. While others focus on basic medical sciences, Dr. Szapocznik built a CTSI that prioritized community engagement and rapid translation to practice. He brought community and university science together in ways that have fundamentally shaped how we think about translational public health research. He's been an incredible mentor and trained a generation of minority investigators who now lead research centers, chair departments, and shape national policy. Which brings us to today and the Public Health Policy Lab. Under Dr. Ana Palacio's leadership, the Policy Lab embodies the same commitment to translational, community-engaged work while tackling new challenges in global health governance. The Bridge Initiative on Regional Cooperation for Pandemic Preparedness across the Global South is exactly the kind of ambitious, equity-focused research we need right now. In a moment, we will hear from one of Jose's mentees about his impact as a mentor. Then Dr. Szapocznik, Dr. Saavedra, and Dr. Palacio will discuss how public health can actually adapt to these challenges through regional approaches and reimagined systems. Dr. Szapocznik, thank you so much for everything you've given to this department and to our field. I'm honored to be here today. Thank you.
Thank you, Dr. McAllister, for those wonderful remarks. I would also now like to recognize Dr. Guillermo Willy Prado, Professor of Nursing and Health Studies, Public Health Sciences, and Psychology at the University of Miami, and former Interim Provost and Executive Vice President for Academic Affairs. Dr. Prado is a pioneer in health disparities and behavioral interventions for Hispanic families, and as an elected member of the National Academy of Medicine. His internationally recognized scholarship has advanced prevention science, and his mentorship shapes the next generation of health disparities researchers and practitioners. Dr. Prado, welcome.
Good afternoon, everybody. It is such a pleasure to be here. I don't have prepared remarks because when I speak of great colleagues and mentors and friends, I really don't need prepared remarks. And this is one of these instances. So we could speak about Jose's many accomplishments, whether it be the CTSI, the CTN, the structure of the department, the $125 million of grants, and everything else that you've heard. What I always remember is the amazing mentorship that I received from Dr. Szapocznik or Jose. So what did that look like, you may ask? Well, I started in 1998 at the Center for Family Studies. And from the very beginning, I knew that Jose was going to be great in helping me because he was, since then, a visionary. He started the Center for Family Studies. So from the very beginning, he gave me opportunities that a lot of faculty, particularly early on in that career, yes, he was a full professor, but he was in his 40s. He was younger than what I am now. And he would give me the opportunity to be the first author of publications of major randomized trials that he was the beneficiary of and the PI of. And so that is something that I have passed down, Jose, since you did that with me the very first time. It also meant that when I had questions and I had feedback and I was working on a paper, he would say, I'm willing to stay in the evenings, or you can come to my house and we can work on it on Saturday. and we would work on it together, at that time on one computer. And after we were done with 2 or 3 pages, he would say, we have to finish this up. And then I would come back the next Saturday and we would have to start from page 1 again. And so all that to say that it was very much an iterative process. He was always willing to sort of fight and champion for what he believed in, particularly when it meant for early career scholars such as myself. So when I was a PhD student, I wanted to apply for an NIH grant. And at the time, the university had not allowed someone who was not on the faculty and have a PhD to apply for NIH funding of their own. And Jose battled with the forces that be, whether it was the vice chair for research in the Department of Psychiatry at the time and the vice provost for research at the university to allow that to happen. And that set a precedence for how the university operates today. And so Jose is about mentorship, but it's also about setting precedent and sort of being a visionary, not only for all that he has done, whether it be in the field of drug abuse, of family therapy, of health disparities, but it's in everything he does and touches. He pioneers new areas. When people are just starting to think of new areas, like, for example, the effects of the built environment on health, he already had an NIH-funded study looking at the effects of the effects of the built environment on the elderly. So it's constantly thinking one step ahead. And it is this vision that is such a magnet for so many of us. Because for me, it's an inspiration, it's admiration, and it's gratitude. And so, Jose, thank you so much for all you have done for me personally, but more importantly, for all of those generations that you have touched indirectly, that you don't even know how many people it is we're talking about. So, gracias.
Thank you, Dr. Prado, for those touching remarks. And I think I speak for many of us here, Dr. Szapocznik, I only second the sentiment there. And thank you very much for your guidance and mentorship. So I would now like to welcome to the stage our moderator, Dr. Palacio. Dr. Palacio, we're deeply grateful for your leadership. And I also invite Dr. Saavedra and Dr. Szapocznik to the table. Thank you.
Mark, I think I'm gonna abridge them. Yeah, in the microphone. Yeah, so we are gonna I'm gonna make my remarks more brief so that we can get back into schedule. But I want to thank you all for being here. I'm thrilled to have you join us as we dive into the critical discussion on navigating public health, policy, and practice in a fragmented world. As Jacob mentioned in his introduction, we will hear from Drs. José Szapocznik and Jorge Saavedra, 2 distinguished voices in the field who will be sharing important insights and reflections on those challenges. This will also be an opportunity for us to thank José for his leadership and ability to translate research into advocacy and action, qualities that have been foundational to the creation of the lab that we are showcasing today. Under his leadership, the lab has delivered a number of significant achievements, and I want to mention just a couple, including the influential work around the World Health Organization Pandemic Treaty through both the establishment of the Panel for a Global Public Health Convention for the 21st Century and a landmark publication in The Lancet Public Health. I encourage you to explore. We are distributing some flyers so that you can be more familiar with the work of the lab in the pages that we distributed. And you can see, let me see, how do I move the page down? I cannot move the slides. So if you could just work on that while I continue. So the lab's work spans multiple scales, from global health governance to regional integration and domestic preparedness. It integrates research, implementation, and education to address fragmentation that we're discussing today. We're grateful to AHF for this collaboration and opportunity to do meaningful work. Jorge and Jose, thank you both for taking the time to be here with us today. And we look to have a meaningful conversation. And please, in the last slide, there is a QR code, so you could use the QR code that will be showing in a minute. So submit questions, or you could also speak at the end of our conversation. And I just want to, next slide, yes. And I just want to kind of like situate the conversation that we're going to have today for a minute. And I think we are experiencing this situation where there is a mistrust in public health. Domestically, one of the clearest signs of this challenge is that erosion of trust in public health institutions and the perception that public health priorities may be at odds with other societal priorities like individual rights and economic growth. This trend was documented in our research where we interview expert stakeholders. That's a project that Jose led. And we interview stakeholders about how to improve pandemic preparedness and response in the state. And we found that low confidence and competing values culminated in a breakdown cooperation that undermined public health responses during the COVID-19 pandemic. And these effects continue to be playing out today. One of the key takeaways from that work is that public health is at a crucial juncture. We must explore ways to better engage the diverse values and perspectives across our country while rebuilding trust in public health. And globally, there also has been a decline in global health aid amid waning appetites for multilateralism and the UN system that has shaped global public health for decades. We're seeing a rise in nationalism and an emphasis on bilateral deals rather than global solidarity. In response, there have been increasing call for strengthening health initiatives across regions. A space where the lab also has been actively conducting research with our study Building Regional Integration for Distributed Governance of Epidemics. These domestic and global dynamics are intertwined, so they are not happening in isolation. This erosion of public health is happening at both the domestic and at the global stage. And it raises important questions about the governance, trust, cooperation, and leadership that is needed for us to rebuild public health. So with that framing in mind, we're going to transition into our chat. Let me get, yeah. Oh, sorry. Yeah. Okay. All right, so let's get started. So I'm going to share. The people in the webinar will hear me from this microphone. They will hear us? Yeah. So no. We're just making sure that people can listen to us while online. Hello? Yes. Okay. So we'll begin our conversation with the domestic part. So my first question will be to Jorge. As I mentioned, we are currently seeing a spike in distrust in public health, which reflects a broader historical trend. Jorge, how is this trend, how do you see this trend manifesting right now in terms of public perception and engagement in public health?
Well, first, thank you very much, Ana Maria. Thank you very much to the University of Miami and to the Policy Lab for inviting me, and of course to the Department of Public Health for allowing this event and accepting to be part of this event. And I will confess that my idea was to come here and to highlight and thank all the work of Dr. Szapocznik. And then when Dr. Szapocznik was told about this panel, he decided to translate it into something else, into a discussion
Action.
of topics. So I will do that anyway later to appreciate the work of Dr. Szapocznik. But right now I will focus on the question that Ana Maria just asked me. And what I do think is that, but it's tricky, you know, the spike of distrust is, and Ana Maria is asking me to focus on the domestic part, but I'm Mexican and I'm here with green card. So it can be risky for me to address domestic topics without the fear of probably ISIS coming.
There is your
But-
answer.
But in any case,
But you're legal, Jorge, are you?
the spike on distrust in public health, it comes from the recent experience, of course, with the pandemic. But during the pandemic, it was partially the fault of us as public health specialists because we didn't know how to communicate properly what the challenges were, what the evidence was supporting, what the evidence was not supporting. So we didn't communicate well. But then you add to that lack of communication skills from public health specialists to the politicians, and then the situation got worse. And that has been, at least for the case of Florida, now reported in this last publication at Frontiers in Public Health that came from the Policy Lab, very well explained what that situation was like during the pandemic. But now the most recent one, I don't think is more to blame the public health specialists. I think is mainly politically motivated and ideologically motivated, and a lot less that has to do with us or with all of you as public health specialists, like it was during the pandemic. But then it's difficult for me also because my work is mainly focusing on global. But whatever happens here in the US, as we say in Mexico, we have a say that reads like, if the US sneezes, Mexico gets pneumonia. And that's what happens in the rest of the world. Whatever is happening here in the US, even if you feel it is unique, sometimes it's not that unique. It is unique that it has an impact in the rest of the world. But it's not that unique that in some other countries, this is not happening. It is happening as well. But of course, here in the US, it's not known. But whatever happens here in the US, it will be very well known in the rest of the world. So that's the challenge, and it is a big challenge.
It is a big challenge. So, Jose, given these challenges, our paper explored taking cultural competence beyond the medical context to inform public health policy and practice more broadly. Can you explain a bit more about this idea and how you see it being applied for, getting more cooperation?
First of all, I want to thank everyone for being here. I feel very honored. And for those of you, Ana and Jorge, who made this happen, and the team, Annie, Rachel, Guy, Jacob, thank you so much. None of this could have happened without your help. So to give you a little back history, cultural competence, the concept of cultural competence came about because health and public health have been 50, 60 years ago, have been designed and developed essentially by white European background men. And the way in which we deliver health and in way we practice public health did not resonate with women and with minority groups, a whole range of diverse groups in the US. And so the awareness arose in the whole field of health of how we had to step out of the way we did things from a white male Eurocentric perspective, and how would we translate what was relevant to different groups. And we were very successful actually in reaching women and minority, specific minority groups by speaking their language. I had a wonderful mentor 50 years ago who used to say, she was a psychotherapist, and she used to say, you go in the patient's door so they come out your door, which meant you first have to meet people where they're at. You have to think the way they think. You have to express yourself in a way that's syntonic to their worldview. And then you have a chance to influence them. And so we thought of this concept and how we would use it today in this polarized world where many of us, those of us here in the room, believe in promoting collective well-being. We do what is best for society, for our community, for our group. But there is a very large part of America today that doesn't see it that way. People who are very much focused on their own individual autonomy and what is important for them. And so the question is, how do we use a cultural competency framework to reach people who have a value system of individual autonomy? I am first. And I think public health is at a crossroads, and it has to transform itself into a discipline that is not just entirely focused on collective well-being, but is also able to reach individuals who believe in individual autonomy. And I thought about a little example. If you have a little advertisement on television and you have someone who looks like that population who believes in individual autonomy, a lot of them are not so well educated, are poor background. And this, say, mother in her mid-30s would say to the audience, no government is going to tell me what I should be doing, and certainly not what I should be doing with my children. I make up my own mind about what's best for me and my children. My uncle Freddie had polio, and he was paralyzed from the waist down. And my cousin Jill was born with hepatitis B. And at a very young age, she needed a liver transplant. And that's why I am making the decision to vaccinate my child against polio and hepatitis B.
So your approach would be trying to produce a bridge between, the collective good, but through the individual lens. So, Jorge, have you seen that type of, since you work globally, have you seen in other places that a strategy, something that we could learn here in the US? Has that worked in other parts of the world? Or how would that look like?
Yeah, well, in some other countries, probably that makes the US more unique, is that it's not much about the individual thinking or individual choices. And in many countries, they believe that whatever the government is telling them to do is based in public health and is going to benefit everyone. That doesn't mean that that's everyone, and everyone agrees with that statement. There is a lot of, as I said, influence from the US about the individual perspective. And I think individual perspective, of course, there are some good things about that. But in terms of public health, well, that's the main difference between public health and individual health, is that we need to think on the public, and public includes all of us collectively. So what I'm saying is that in that case, the massive amount of people that think differently here in the US, probably you don't find it in some other countries.
And so, Jose, maybe what we need to do is rethink the classes that we teach in public health, correct? So, because what you're saying is a little bit of psychology, a little bit of communication, and those are not necessarily the things that we teach. We teach epidemiology, we teach other things. So, maybe how do you view the reshaping of public health from the ground up?
Well, I think one of the strategies is that we need to bring into our faculties people who have that perspective and can help us from the inside to reshape public health in a way that resonates with them and the people who think like them. We need collaborators from the other side. As, by the way, as we do anytime we do behavioral interventions, we always have to get what we call indigenous collaborators, collaborators that are part of that world that we're trying to impact.
So that would take much more, because usually you want to preach to the choir. We love preaching to the choir, no? So we recruit people that align with us. So what you're saying is, on purpose, how this reshaping should look like is that we, instead of seeking people that align with us, we should see people that bring diversity of voices. That is a way to get started.
Yes.
And how do you work through the tensions that we are experiencing right now? Like, for example, we have this issue of the vaccines that you are raising. What would be steps that we could take as public health agents right now before we reshape public health? How do we reconcile this tension? Because we have children getting now measles and all sort of things that they should be not having. So what could be steps that we could take?
What are the small steps in the short term? Well, let's think about how we do it, how we've been doing it for many years. Let's say that we want to reach the African American community. The first thing we do is we hire some African Americans that represent that community that can collaborate with us. And we partner. Actually, 70 years ago, anthropologists were talking about having someone who is inside the group and somebody who's outside the group. We're the person outside the group. Now we need someone inside the group to create a dialogue with the group. Was it Florence Clockham that talked about that? I forget. One of the very famous female anthropologists of the 50s.
Okay. All right. So let's move a little bit towards now the global scene. And our bridge study, along with the broader literature, has shown growing momentum for regional approaches to health governance as an alternative to traditional multilateralism. How do you see us driving this trend? What certain regions are going to be more prone to organize this way? What is your vision of how is this going to pan out?
Yeah. So going back a bit, especially since World War II, the world has been very interested in multilateralism, led by the US. And so we established the United Nations and the World Health Organization and the World Bank and all of these international multilateral organizations. The US has now withdrawn from the multilateral perspective. And so, and the US has always been the biggest support for that effort. So that now the rest of the world has to say, what do we do now? And actually, I don't know if you heard the Prime Minister of Canada, Mark Carney, spoke at Davos, and he said, this is the time when the middle powers, countries like Canada, have to join together to collaborate around economic issues, political issues, and health issues. I'm adding the health part of it. He didn't say health. But this is what we need to do, is to develop coalitions of the willing. And we see examples of this many years back, the European Union. And so the European Union was a group of countries that wanted to collaborate politically, economically, in a humanitarian vision. And so they came together and they created a new political and new economic infrastructure. More recently, we've seen in Africa, the region of Africa developed the African Union, which is a political coalition in its infancy. And then they went one step further and they developed a CDC for Africa to look after the health of Africans. So we have to look for these coalitions of countries that are willing, and these are regions usually.
Mm-hmm. Yes, and we've seen this example in Africa. I know, Jorge, that you've been one of the authors of a commentary in The Lancet calling for the establishment of one such center for Latin America. But right now, there is no cohesive member state-led organization in the region, although we have PAHO, that is a branch of the part of the WHO, and some other sub-regional bodies. But what are the gaps that we have? We have PAHO and we have these other, regional, sub-regional things. What are the gaps that you see in Latin America that justify the CDC for Latin America?
Okay, just before going to Latin America, I will just agree with Jose that the US was the main motor that created the multilateral system, but now it's the main motor that doing exactly the opposite. And that's a challenge for the rest of the world. And not just because the Prime Minister of Canada said it, but he said it beautifully, but also because it makes sense. It makes sense mainly in terms of public health. Many of the public health emergencies that have been global, including, of course, COVID-19, they became regional first. It was the case of Zika in the past. It was Latin America mainly. Later, it exported to the US, especially here to Miami. But many of them are regional before becoming pandemics or before becoming global threats. So it was a case of Ebola in Africa as well, SARS in Asia. Many of them, they have been like that in the past, and they will continue to be. So it makes sense to have these kind of regional approaches to public health before they become international or global. And by saying that, then I focus in the case of Latin America. There was a big investment to try to make Africa as a model of regional collaboration with the support of the US and China. The two of them worked together to create the CDC for Africa that is working well, at least compared to other developing regions of the world. The CDC Africa is working well. And that's what we started to learn, like from Latin America. Why is it that we don't have something like that in Latin America? And someone told us that's because we already have PAHO. So we say, well, how can PAHO be Latin American if it is based in Washington, D.C.? And in the case of CDC Africa, it's based in Ethiopia. That means it's based in Africa. And also the votes, the governance model of the CDC Africa is about the African governments. In the case of PAHO, it's not just Latin America, it's the Caribbean, it's the US, it's Canada, and it's based in the US. So, and they are also the office of the WHO. So they have a different mandate. And now, of course, we know that the WHO is suffering because what is happening with the US, the withdrawal of the US. So what we think is it makes a lot of sense for Latin America to become a regional way of a mechanism, at least, not probably an organization yet, but a mechanism to deal with public health emergencies. And that was the idea behind the comment at the Lancet of why Latin America needs its own CDC. Now we are trying to convince PAHO that it's good for them to also support this idea, because it was never meant to replace PAHO, but it was meant mainly to have something regionally that can respond to regional emergencies before they become international.
Yep. So in that vein, the gaps, I know some of us that have roots in Latin America during the pandemic, we kind of encountered that firsthand, correct? That people didn't have information, they didn't have supplies. And then the countries were reaching out to individual people like us, kind of you help us through the door of something. We need to get some vaccines. Was that unique to Ecuador, or did you experience that at that time was kind of like everyone fighting the neighbor trying to get supplies? How, because you were more in touch. I was just like with my home country communicating. How did you view that?
Yeah, because what happened, well, probably not everybody knows what happened in Ecuador. Recently, there was a webinar organized by the UN Policy Lab, where we have one of the speakers was the former president of Ecuador, who was president during the pandemic, and he told us about the challenges that Ecuador was facing. But for me, it was sounding like Mexico, and it was sounding like Bolivia, and it was sounding like Colombia, because every single country was trying to deal with their own resources, with their own means, because the international collaboration was not there. Vaccines, they were kidnapped at the countries of origin, kept there, and many of the drugs, even the ventilators, even the face masks, they were not widely available. So every single country was trying to do their best with their own resources. And that meant that the international collaboration or global collaboration in terms of public health was not working.
Correct. And there is a little bit of like short-sightedness, because what we, at least in Ecuador, saw was that there was kind of like the health diplomacy, but not coming from the US, but coming from adversaries of the US, So Russia and China just giving away the vaccine, obviously, usually with some strings that position them closer to Latin America. So there is also like a political short-sightedness about health diplomacy. So is there a hope for health diplomacy as you can see it now?
Yeah, definitely. It's not just about health, but diplomacy in general. But whenever the US withdraws from something, someone else will come and fill the gap. And that happened during the pandemic, in many cases from China. We in Mexico, we started the vaccination with Chinese vaccines. Same in Ecuador.
Yeah.
And I was told it's the same thing happened in many places in Latin America. We started using Chinese and Russian vaccines because the other vaccines were not available there. So yes, I mean, it happens in all the fields, but especially in public health.
Yeah. So Jose, I remember that you and I went to Ecuador like 12 years ago, with the idea of empowering people to do this participatory approach and the idea of building their systems, learning the lessons. So we didn't have a lot of luck because people still, is what you're saying, everyone wants to do the things their way. And if you come to try to put some light, go this direction, it is a no. So now, after all these experiences, how do you think we can help, if not parachuting into countries, but how can we build relationships so that we can, share the lessons that we have learned to countries like Ecuador or others?
Well, I think that's where an organization like a Latin American CDC could be so valuable, because what used to make the US CDC so special was that it was very science focused. And so they will, if we can establish in Latin America a CDC that is science focused, that is an objective consumer of scientific findings, then they will seek this kind of expertise. But they're inside. I was talking about in anthropology, the inside and outside person. We are always the outside person. And the CDC could be the inside team that brings us in if they think that we're appropriate for their needs. But I wanted to say something else about what the quality of such an organization. They have to have autonomy. And we saw when the CDC in the US was autonomous, it had scientific credibility. Once it's lost its autonomy, it lost its scientific credibility. But we can also look at the example of PAHO and the WHO. they are somewhat autonomous, but they are not, because their board of governors are all the countries that are members. And so anything they do there has to be unanimous approval by all countries. And whatever they're able to do is very vanilla, is very basic, very bland, because how do you get all countries to agree? By not taking any strong positions. And so an organization in Latin America or another region has to have autonomy. And for me, autonomy means funding structure. So if you look at the WHO, the reason the WHO fails to be autonomous is because their income, only 18% of their income comes from fees that the countries are mandated to pay. The rest of it is voluntary donations from countries. And so every country comes and says, I'll give you $1 billion, but this is what I want you to do. And so they're no longer autonomous. So we need a regional body that is science-based, that has a funding structure that allows us to make its own decisions and not be politically influenced.
It's a tall order seems
A tall order.
right now. Jorge, how you have established this collaboration with How do you think? And we created this lab, and we're working in its space. And Jose has done a lot of this work. What are the things you think universities like ours or labs like ours could do to try to bring stakeholders at the table and start to move the needle forward into this buying into wanting to do this, getting the political will?
Yes, and one good thing that we thought it was needed, and we spoke with Ana Maria, it was to share inside the community what we are jointly doing or what we are doing together with this collaboration. And that started in 2016 when we were thinking on how to address public health issues at the global level from the AIDS Healthcare Foundation. And we decided not to start our own from zero because we are not an academic organization. We are providers of HIV care, actually the largest providers of HIV care in the world. But in terms of public health was kind of, in terms of global public health, was a completely different idea and something really new. So what we first did was to knock the doors of the University of Miami and to try to see if we can do it together, so we don't start from zero, from no academic experience, to do it with someone who are more academic and have more systematic approaches to these kinds of works. And yes, we were advised to go with Dr. Szapocznik. And that's the way we started this collaboration with the Later, it was translated into the Global Public Health Policy Lab, or the Policy Lab. So what we do now, right now, in terms of collaboration, is we are in 50 countries right now as AIDS Healthcare Foundation. What we do, though, there is usually by invitation by the governments, or sometimes by NGOs, or sometimes by other partners, but we sign MOUs like we did with the So that means that we have kind of partnership. We don't like to describe ourselves as funders or donors, nothing like that, but partners. Mm-hmm. So to do it jointly. Mm-hmm. And that's why we were really pleased to see that here at the what we receive is kind of partnership, not a different kind of a relationship, like, okay, you are the NIH, so give us the money. No, it was not like that. We also provide services. So right now, we are we're in the middle of starting something that is already evolving, like a retention project with HIV care patients here in Southern Florida with the And Ana Maria is leading that process, and with some other policy lab team. And we think that we can to strengthen this collaboration in terms of more specific goals, not just in global governance of health, which has been amazing collaboration, but also in some more specific duties that has to do with care.
Great. Jose, finally, if you were to be speaking to somebody just starting out in public health, a student, a really proud of today, what would you say to inspire someone that is getting started in this context?
Yeah, I get that. What is behind your question is this is such a difficult time for public health.
Yes.
There is so much distrust of public health, and this is at the same time, as the Chinese say, crises are times of opportunities, and so this is a time when public health must reinvent itself. It must think it must look at ways of influencing the world that is very different from the way they have in the past, because so much of the world doesn't trust us. And so the opportunities for a young person to innovate, to have a vision of what public health could look like in the future are enormous. This is a really great opportunity for young people to create new paths in public health.
Thank you. All right, thank you. What we're going to do now is open it for questions from the audience, either in person or virtually. So if you want to take away one of these mics, if anyone has a comment or a question, maybe we can get this mic out of here.
Thank you so much. And it's such a delightful moment to be here to honor you, Jose. And
Can you speak louder?
yes, thank you so much. It's beautiful to be here to honor you. Thank you, Jorge, for all your dedication over these years. And thank you, Ana, for putting all this together. So you alluded to individualism and individualistic values. My concern is about the lack of social empathy, It's not just about people treasuring individuality, is the sense that it doesn't happen to me. It's someone else's problem. It's not here. It's somewhere else. So do you have any ideas on how do we bridge? What are specific avenues to increase social empathy on that, the problem and social responsibility? And how do we begin with that?
I don't know about social empathy specifically, but the way that is typically done is by getting people who lack social empathy to get to know the other side, to get to know an individual in the other side, and to then begin to think about not just them, but I know Viviana, and she's a real human being. And that's how we begin to develop empathy in people. It's the connection, with a real human connection with somebody on the other side. And I know, for example, in Israel, where I live part of the time, there are a number of movements to create dialogue between Palestinians and Israelis. And so one of our relatives actually directs a program like that. And they hold, there is a park where every weekend night, people come from both sides and they have conversations. And so they get to know each other. So it's not just anymore them, but real people who can talk about their own sorrows, their own experiences, and they get to know each other as real human beings, establish bonds, and become friends. And maybe that's what's needed here. We have to bridge across the polarization. Yes.
I think he is about to go.
Okay.
He and then
Jose, we talked, the panel talked a little bit about the erosion of the panel talked a little bit about the erosion of trust that has taken place in public health institutions. And I'm curious to get your viewpoint as to what is the degree of responsibility that the institutions themselves have for that erosion of trust, even preceding COVID, right? If we look at American society, we see a sick population, right? With metabolic disease, with mental health illness, with addictions and the policies that were coming from the top during the opioid health crisis. So how much responsibility do the institutions themselves have for this erosion of trust that we see in practice?
I think the public health institutions have a lot of responsibility. And we talk about that in the paper, the distrust paper that was recently published, that we have been very arrogant. And we've always taken the perspective in public health that obviously we are right. And the well-being of the collective is more important than individual autonomy. And so what we were doing is we were putting down people who didn't think like us. We were stigmatizing them. And when we stigmatize people, we push them away. We push them into their own group. And sometimes after a while, as a defense mechanism, they even become proud of the label we've given them, the anti-vaxxers, the anti-science. So we have a tremendous amount of responsibility for having been so centered in our public health culture and not have been sensitive to the culture of those who had a different perspective.
Over there, okay. Good afternoon. It's a pleasure to be here. I also want to extend greetings from Dean Ford, who is unfortunately on a plane right now and could not meet with us. But I have a question about communication and whether we in public health and those of us in this room are really losing the public's interest or the public's trust because of our lack of ability to communicate to our population the message that we want to have out there. I heard the editor-in-chief of Science say that he was really impressed by the fact that he had 4 million people on his social media following science publications, etc. But then he said, but Charlemagne the God has 400 million people following him. So how are we going to get the word out that says to our population, look, I'm a vaxxer, right? Why aren't we claiming that and making that this statement rather than giving and ceding to those who are a smaller percentage of the population, but a very loud one, that, they're anti this, anti that, when we are very pro science and pro vaccinations and pro the good that we do. So I would challenge the younger generation, because I think I'm way past trying to figure out social media, how we get that message out there, because I think we have given up a large part of the public trust. because we can't communicate. And we can talk among ourselves, but we need to be talking out there. So just a thought, I'd love to hear your thoughts on how we do that, or maybe the audience think about how we do it too. So thanks.
Anyone in the audience wants to respond? Yes.
Thank you. I think first, very interesting and insightful panel. And I think the issue of communication is very key. And the fact that you referenced Charlemagne the God, it also points to the fact that when it comes to public health information, we have to move with the times. So for example, influencers have become common. Wherever you turn, whether it's on TikTok, whether it's on Instagram, whether it's in the community gathering, there is an influencer. And these are voices that are very important. These are voices that have huge followership. So it's getting them to also be the messenger of public health. But another important thing is breaking down the information. We can all speak here as experts, but the person who lives or who is outside on the street or by the roadside or somewhere in the market doesn't understand the lingos that we use. So breaking down public health information in a way that it is easier for communities to understand and also translate them, that also becomes very important. And I think another thing is with public health is we're missing the storytelling part of it, because that is what translates data into tangible humanity. So it's being able to connect it to lived experiences, tell the stories of people, and use that to get people to believe in the data, to believe in the science, and to also follow it. So it's basically public health has to move with the times that we're in when it comes to communication. Thank you.
Thank you. You know, there are two parts to communication. One part is what I want to say, and the other part is what you hear. And I think that one of the foundational principles of public health, I believe, is that we must be able to communicate in ways that resonate with the other person. It's not what I want to say, is how can I communicate in a way that resonates with you, with who you are, with what you believe, with what your ancestry, your history, your experience is. And so that word resonate, we have to bring back to public health. It's gotten lost.
So let me make a plug. Just one plug for us in the department is, I teach a course. And for those of you that teach a course, what I see is that we have a difficulty communicating, and that we should include these messaging communication in all our classes, and maybe even have some formal courses on how to communicate, because I see kind of like that is less the common thing that the students know how to communicate effectively. I think we're kind of like seeing less and less of that because they're growing up more in the computer. I don't know what the variables are. But I think we need to think about, when we think about competencies, that the communication part is a competency that is key and that we should include it.
Yeah, actually, the department used to have a course that was taught together between public health and the School of Communication. And do you want to speak to that? And our students were learning from School of Communication faculty and students how to communicate, and projects were done in collaboration. One public health student, one communication student together did a project.
I actually wasn't going to talk about that at that moment, and I had a question. I felt for a long period of time of working with different disciplines and getting different points of view from different perspectives was always important. I think we did that over 10 years ago, more than 10 years ago, where you can bring in the effective communication and those communication skills with public health. So I'm not sure how much more you want me to talk about that, but that was something under your leadership that was really important to the creation of these transdisciplinary approaches where health became part of the larger discussion. Which brings me to my question. And I'm getting back a little bit more to the global public health framework here in which you have been talking about, and I really appreciate that and the work you're doing. I think it's so important. And you also mentioned the rise of multilateralism post-World War II, which founded the World Health Organization. But we often forget that the multilateral agencies that were developed, and specifically the World Health Organization, was developed for the purpose of peace and security and the cooperation of nation states and people. And that was how it's founded. But when we start to talk about global health or global public health, we forget that. And we focus on health and we forget about peace and security. We forget about the integration of those. And I'm wondering how you can see as the future in both education, higher education specifically, and practice, that can be reintroduced to be most effective.
I'll let others answer that.
What I can try to say, I'm not sure, I'm sure it's not the perfect answer, but the concept of health security was introduced like in a way of matching what you just said, that it was a peace and security. But there is this concept of health security or global health security. And that sometimes is easily understood, especially by rich countries, because they want health security from things that are happening in developing countries, like neglectable tropical diseases and things that can spread to here. So sometimes they are willing to invest to that in terms of their own health security. But sometimes that global health security in developing countries is translated into, okay, it's a way for protecting them, not necessarily for protecting ourselves. And yeah, that's the interpretation of that. But I very much agree. That was the initial multilateral agreement for peace and security. That was the initial stage. I don't know if right now with the Board of Peace is right now going on that direction again, but or it's a different kind of thing. But what we think is that this way of making public health as a global issue, it was quite manifested during the pandemic. I mean, we started working on the idea of a global public health convention before the pandemic. And I remember Dr. Szapocznik and I were struggling to get the interest of public health specialists on the topic of a new way of agreeing on public health as a global thing in convention. But it was until the pandemic started hitting everyone that public health specialists started to get interest on our topic. So we had a lot of people reaching to us that they wanted to contribute to the idea. So, but yeah. I know it's not exactly what you asked.
Well, I think we skip to global security or global health security, and we forget the whole diplomacy side of that, which is where, the peace and security come in. And, I don't see many courses or many people who are involved in global health that are well attuned into understanding the need for global diplomacy and global health diplomacy specifically. I don't know how you all feel about that, because I think that's such an important component.
Yeah, it's not a specialty here, but there are schools of public health, such as Georgetown, where global public health and public health security is a major topic.
I forgot to mention, but I didn't forget to mention it didn't come to my mind until now. The AIDS Healthcare Foundation, we had like every month policy think tank discussions. It's a global discussion, but it's just internal to AIDS Healthcare Foundation. And this last Tuesday was about health diplomacy. global health diplomacy. And I want to mention and highlight that the idea and trying to find the proper articles to discuss was raised by my colleague Kemi, who is here as well, who's our communication expert as well. So we discuss about that, and that's quite relevant. We very much agree.
So great discussion. You spent a little bit of time speaking about the withdrawal of.
Can you speak up, please?
Sure. We spent a little bit of time speaking about the withdrawal of the United States as a leader in this multilateral, multinational organization. And we're seeing some interesting things happen. So the question is this really an all or none question as it relates to the United States, all in or all out? In the last 2 weeks, we've seen 2 states, California and Illinois, declare their desire to join the WHO. So my question for you guys who are in this space, is that a good thing or a bad thing?
California wants to join WHO. I don't think they can. They're not a state.
They are states.
They actually are a state.
Not a nation. Not a nation.
But probably as donors, they can be donors.
I'm not a constitutional scholar, but as the U.S. is organized in the Constitution, each state actually does have the ability to participate internationally in organizations. So.
That'd be good or bad? Oh, 1 minute.
So should we galvanize this and
Can you speak
help?
up, please?
Yes. So should we galvanize based on that the emergence of these 2 states wanting to join other states such as ours? That's maybe for the Catalyst Lab.
Yeah, but one thing is that if the US allows them to do, and then reforming the WHO to make it that possible. Because according to right now to the constitution of the WHO, that is not possible. I mean, we have been fighting also to include like civil society, universities into the governance models of the WHO, and they say, no, it's just member states, and that means countries.
So my last comment is regarding similar of the topics that you were talking about. I used to work for USAID. So I think that is kind of the diplomacy side that we have somehow lost. And my question, and I was in the front lines during the COVID-19 pandemic, coordinating the response supported by the US in Central America. And it was very interesting, and it's very different from what I hear other Latin American countries experience, because the US helped distribute ventilators, helped to develop the oxygen supply, laboratory capacity, physicians training, IPC, like you called it, like we did a great job, like the US did a great job. And also distributing vaccines. So, I mean, I feel still very sad about the things that this country and the world has lost because of USAID. But I also know that the State Department continues funding pandemic preparedness projects. It's the only one or one of the few that survived. So my question is why, and I think Miami, the University of Miami, it plays in such a strategic point because you have the connection with the region and also with the US. So what kind of role can the Policy Lab and play in this context to advocate for more support, more diplomacy to expand the efforts in pandemic preparedness and response?
You know, I'm very jaded at this point in what some of us can do to advocate for more support, international support for health, because our leadership of this country doesn't want it. I just don't know if they would be, if we could make any difference. I wish we could.
So, I'm going to just throw a wrench into the whole thing. We need to move on in a minute, but I want to throw the wrench of security because, you know, when you said that, it came to my mind something about the US. And I'm a clinician, and I think there is a few clinicians in the room. And when you talk to patients, you can see that they don't feel secure. In the US, people are not feeling secure. They are not feeling listened by their providers. They feel that there's them against a system that is wanting to charge them for everything, that the medications, you know, are not coming, that there is somebody out to get them, because sometimes there is a system that, you know, of the financial structure that really is playing against them. So when you talk to patients, you see patients that even though have a roof over their heads and are not in a war zone, that are really despondent and feel hopeless and feel lonely, and they don't feel secure in their doctor's office because they don't know how much it's going to cost and what is next. So I think maybe that is one of the reasons that we are failing in public health, because if you have people in survival mode, their empathy is going to go down. So I think some of the answer maybe when we say next steps, I think the way of the health system, how it's working, is really playing against us. And it can also be a priority for us in whatever way we can to make our patients feel safe, or at least listened to, or so that they feel that the academic, the clinics, you know, that providers, we are on their side, because now we are becoming the other side. And that is something that is quite unnerving, you know, to think about that the patient that you're trying to serve somebody and that they see you as the adversary rather than their, you know, the champion. So I want to throw that wrench, and we need to move on. But I, you know, we should continue this conversation. But as you talk about security as a foundation, that feeling that I get sometimes getting out of a room, seeing a patient, you know, is that how can I make this person feel safe in my office? And I think that should be a priority for us to think about. Well, thank you so much for all the great questions. We are going to move on to the next, you know, to honoring Jose. So go take it away, Jacob.
Great. Thank you so much to our panelists and to our audience for engaging in this conversation. So we have a recorded video message. If we could get it to work. Let's see. Let's go here. Yeah.
Hello, I am Julio Frenk, Chancellor of UCLA. I want to take a few moments to talk about Professor José Szapocznik and his profound contributions to global health. Many know José as the founder of Brief Strategic Family Therapy and other influential interventions for troubled teens and families. He also chaired the Department of Public Health Sciences at the University of Miami. But in my time as president of that university, I saw another side of José's impact. I watched him raise our global defenses against infectious disease. José saw critical gaps in the way public health efforts were structured from country to country and from health system to health system. There was also a gap between research and advocacy. Those gaps cost real human lives. Together with the AHF Global Public Health Institute, his team convened a panel of global leaders. Their goal was clear and critical: to prevent, prepare, and respond to infectious disease outbreaks before they become pandemics. They worked with keen urgency. In only a few years, the Global Public Health Convention has achieved unprecedented success, an international public health framework against pandemics founded on evidence, commitment, and trust. José Szapocznik helped turn the tragedy and trauma of COVID-19 into a blueprint for a healthier future for everyone. For that, all of us are grateful and safer.
So with that, we'll move to honoring Dr. Szapocznik, and I'll turn it to my colleague, Annika Liu, for remarks.
Hi, everyone. My name is Annie, and I'm also one of Jose's many mentees. I want to just take a moment to say a few things. We've heard from a lot of distinguished guests already about Jose's extremely impactful work. Your work is not only advancing the field in so many different disciplines that we've heard about, from global public health accountability and equity to the built environment to substance use and mental health. But as Dr. Julio Frenk said, your work is saving lives. And this is a sentiment that, in conversation with several mentees, we really wanted to emphasize, and we look up to you and, can only hope to live up to stand in shoes as big as yours. And we're also really extremely grateful to be impacted and shaped by you. And we also heard from Dr. Willie Prado about mentorship, right? Like, you are such a champion and can see potential and really believe in us. And I just want to say thank you so much for believing in me. And one very small vignette is, like, I was working with Jose as a grad student and later worked on his team as a senior research associate. And he really incessantly was telling me, like, you should apply for a PhD program. And you believed in me when I didn't even fully believe in myself. And there was one time when he took a screenshot of me, because we were in a lot of virtual meetings, and he said, "Today you look like a professor," and you emailed it to me. And I feel extremely touched just working with you, and just so grateful. So with that, on behalf of the University of Miami Public Health Policy Lab team, we'd like to present this plaque in recognition of your visionary leadership, heartfelt mentorship, and enduring contributions to advancing global public health. We love you so much, Jose.
Thank you so much. Thank you so much. I'm so humbled and so honored by all of you being here today, and the amazing words that you've all expressed. And you have been a very important part of making all this happen. So thank you so much. And please keep up the good work. There's a lot of work to be done yet. And it's up to you. I'm on my way to retirement. So it's up to you all to get it done. Thank you.
And now for some remarks from AIDS Healthcare Foundation as well.
And on behalf of AIDS Healthcare Foundation, AHF Global Public Health Institute, the team here, Kemi, Guy, Juan Manuel, Ariel, and Sandy, we would also like to give you a plaque, and I will read it. Because for us, I mean, we have been collaborating in many things with the University of Miami, but in this case, and this specific case, we want to do this in recognition of your exceptional leadership and outstanding contributions to the Global Health Convention for the 21st century. Thank you very much, Jose.
Thank you. AHF has been an amazing partner, and Jorge alluded to this. In 2019, Jorge and his CEO at AHF, Michael Weinstein, approached me and talked about how do we prevent a next pandemic. And this is before anybody knew there was going to be a pandemic. So they're real visionaries. Thank you for your work.
Great. Well, in closing, I just want to one more time thank Dr. Szapocznik, Dr. Saavedra, and our moderator, Dr. Ana Palacio, and of course our audience for engaging with us today. Please do stay tuned for updates from the UN Public Health Policy Lab, not only hybrid or in-person events like this, but also our bi-monthly webinar series, Emerging Challenges in Global Public Health. Thank you very much, and we look forward to staying connected.